All right, guys, we're at part 2 of the gastroenterology. Now we're going to go into the very things that are extremely specific to the abdomen and in abdominal problems, specifically with the gastrointestinal tract. Understand that there are other organs in there. There's kidneys, there's reproductive organs, all, by the way, referred pains from the heart that can cause abdominal pain. So, but when we're talking about these things, we're talking about specifically to the gastrointestinal tract. Remember from A and P that if we stretch this thing out, I think it's 3 football fields is what it would end up being. So again, it's a very long, 30 feet of bowel is what you've got in there that's kind of wrapped up, okay? So, again, remember you got other organs involved, the liver, the gallbladder, the pancreas, your appendix, again, and we're going to talk about that guy. And, again, the thing that our gastrointestinal tract does is it breaks down the food in order for us to use it for nutrients and energy, okay? And if you look at all of these things, there is a ton of things in the abdomen, okay? There are just absolutely a tons of things, and all of them can cause pain when they cause problems, okay? So, again, as a piece of food passes through the GI tract, the nutrients are absorbed, and then the solid waste is formed, and then it's excreted, aka you go poo-poo. All right, so your GI bleeding, and again, the bleeding from the gastrointestinal tract proximal to the ligates of Treats. So where is the ligate of Treats at? Again, it's at the pyloric junction. So at anything lower, basically just past where your esophagus starts would be considered upper gastrointestinal bleeding. Okay. Now, 300,000 hospitals, and by the way, these are the guys we get there that they're vomiting red blood, if I can say it right. And then they're usually trying to treat themselves with the over-the-counter medicines. These are your peptic ulcers, your gastritis, your variceal ruptures, the Mallory-Weiss tear, which is an esophageal laceration, if you have esophagitis or duodenaitis, okay? So the ligament of Treats is actually just a little bit lower. It's kind of separates your ileum and the duodenum from the jejunum, okay? So it's a little bit into the GI tract. Now, again, usually, guys, they have hematemesis, which is the bloody vomit, and if it's going through part of the lower GI tract, you're going to see the melena, the black tarry stool. Both of those terms I would do. Hematochezia is the other one I would probably know, which is the clumps of blood in the stool. Okay, blood in emesis that is usually bright red, or it looks like a coffee ground material. And again, it can be light, it can be brisk, and if it's light and it's red and it's coming up the wrong way, probably you could have a serious amount of blood loss from that. Okay, the tilt test, by the way, indicates that the patient has orthostatic hypotension. Again, that's not a bad thing to do if you think that the patient's lost a lot of blood. Just be aware that you're good and you're going to get some dizziness, weakness with doing that. So be careful when you're doing a tilt test. Again, the patient's appearance may be the best indicator. Skin signs tell all. If they've been losing a lot of blood through the gastrointestinal tract, you'll probably find it that way. Again, treat the patient. Make sure that they're prepared in case they start to vomit. Low Fowler's, again, left lateral recumbent position. Whatever the patient is most comfortable in, just make sure that you can make sure that the airway continues to stay clear. If you think that you've got gastrointestinal bleeding, 2 large bores IVs. And I'm going to give you guys a little hint on maybe your scenarios that are coming up. If you get in there and you see a whole bunch of blood everywhere in a scenario and it looks like they've been throwing it up, the scoop and run method is a really dumb idea, okay? I'm going to pick them up and I'm going to carry them out to my stretcher. I hope you enjoy doing CPR when you do that, okay? Sometimes you need to stabilize the patient where they're at, so keep that in mind. Especially if you got a lot of GI bleeding, maybe you need to get that blood pressure up a little bit before you decide to do something really stupid, like, I don't know, involuntarily pick them up and therefore raise their body up, and therefore, you just drop their blood pressure to a very dangerous level. Esophageal varices, they're swollen veins in the esophagus. They rupture. When they do rupture, gang, probably 4 out of 10 die. Again, it's an increase of the pressure inside of that gastrointestinal tract. Consumption of alcohol doesn't help. They ingest a caustic substance. By a liver cirrhosis, by the way, are 2/3 of the cases of this. There's an underlying liver cirrhosis and they don't know it. And again, rapid airway management, fluid resuscitation, and immediate transport, getting them somewhere with blood products. Again, they need to go in and have treatment. Octreotide is the drug of choice for acute variceal bleeding. So that helps essentially pharmacologically seal off those. But again, we don't carry that, and therefore we need to get them to the hospital. So this would be an example of the esophageal varices when they pop, and again, it can cause major problems with that. Now, gastritis, gastroenteritis, again, it's the inflammation of the stomach and the intestines. Usually we do that due to some sort of parasite gets in the tract. And again, the problem is they can't, that if they've got alcohol or tobacco abuse, they're at a higher risk for that. And usually if they've been on an aspirin regimen, Aleve is another one that can cause the surface of the stomach and a breakdown of the GI tract. And then again, very severe, very painful. It can lead to fluid loss, can lead to dehydration. The problem is they just can't eat or drink anything, which makes things even worse in that case. Again, supportive care for these guys. If they are dehydrated, again, start a fluid resuscitation regimen on them. Your chronic gastroenteritis, again, by the way, can be due to a microbial infection. And again, it's very prevalent in underdeveloped countries. And by the way, it's transmitted via the fecal-oral route. So that's, again, somebody went swimming in the dirty pool water. Guess what? Congratulations, you got that. All right. So again, the nausea, vomiting, fever, it's usually the H. pylori symptoms or your heartburn. H. pylori actually end up causing peptic ulcers, by the way. So the best thing that you can do is, again, proper contamination, monitor their ABCs, and we're going to make sure we take them to the hospital. Again, your peptic ulcers, again, the erosion. By the way, that H. pylori, they love to throw that one in on the test. I don't know why. I've seen it on my last 2 that I've taken, so it was kind of weird. Duodenal ulcers, again, occur in the proximal portion of the duodenum. Occurs more in the male than the females, and they think that it is related to stress as far as that goes, but it's actually also a viral component of that, and they can use an antiviral to actually help stop that H. pylori bacteria. And then the treatment in the pre-hospital setting is, again, an antacid treatment if you're allowed to give those, and then, again, support any type of hemorrhage that you might have from that. The problem is it can block the pancreatic duct, which is, again, going to cause more colicky pain, more with your gallbladder, okay? Again, nausea, vomiting is very common with your peptic ulcer. And if they rupture, yes, they can cause massive hemorrhage. And the patients are going to look really ill, instability. They might not even know that they're bleeding, okay? To be honest with you, they might not even know that. Cyclic vomiting syndrome. Menstruations, infections, yes, motion sicknesses, but they start vomiting and they keep vomiting, and it's a very horrific cycle, okay? The other thing is, by the way, sometimes pregnancy can actually cause this. So again, it results in dehydration, esophagitis, and it tears the upper GI tract. Again, IV hydration is usually your best way, and an antiemetic is, it's not a bad idea. Actually, that's the one time I would say your Zofran's probably not necessarily a bad idea here. Your lower GI diseases, again, usually it's where all the nutrients are absorbed, the breakdown is stopped, the water is absorbed, the solid waste from that lower diseases. And again, it occurs in the distal tract, distance ligament accretes, and that's the conjunction with the disorders that happen down there. And we'll talk about these are the specific disorders, and we're going to talk about them real quick. Again, cramping, nausea, vomiting usually goes on with your lower GI bleeding. Again, usually a melena or a hematochezia is what you're going to have. Ulcerative colitis, again, this is an idiopathic. It happens within the person, inflammatory bowel disorder. And again, it usually causes irritable bowel syndrome. Pancolitis spreads through the entire colon. And procolitis it's only limited to the rectal area. And again, a lot of the things there's what you ate, toxic inputs, immunologic problems, and again, recurrent disorder. Usually, you've got the bloody diarrhea or stools with that. And again, you're going to get some abdominal cramping. And again, the hemorrhage is what we're worried about the most here. And then again, it's a transport and again, lower GI bleeding with colicky pain. They need additional treatment that we cannot give. Okay. So ulcerative, again, this is kind of an example of the ulcers that are in the colon and they start to bleed. This is where you're going to get a lot of that clotting blood type of thing. Crohn's disease, very frequent in the Jewish population, but it can happen in anybody, okay? Usually they tend to run in families, essentially it causes damage to the bowel. It can occur anywhere from the mouth to the rectum. It can actually obstruct the bowel and, surgical emergency where they're actually going to have to go in and clear that out. And it does do significant lower GI bleeding. One other little nice comment here, and this is only because I had a partner at one time that had Crohn's disease. Excuse me. When they say that they have to go to the restroom, believe them, okay? It's coming. It is coming, and they cannot stop it. And when I say it's coming, I mean explosive diarrhea, okay? So they need to be on the way to doing their thing, okay? So the management depends upon the patient's physiological status, okay? And again, usually we fluid resuscitation, actually not a bad thing here, but again, it's largely palliative. I've known of Crohn's patients that actually have to get literally feet of obstructed bowel or gangrenous bowel taken out. Extremely painful, by the way. Diverticulitis, it's a complication usually of diverticulosis, and in the presence of intestines, the small outpouchings that do the absorbing, and those muscles, they get inflamed, and it's extremely painful. And so diverticulitis is a secondary usually to an infection. It swells these areas up, causes really terrible pain, and it's diffuse as well. Antibiotic therapy, they'll usually go in to make sure that there's nothing blocked, and again, x-ray to make sure to verify that. Hemorrhoid, yes, a true pain in the butt. All right, well, there's swollen veins that occur in the anus or the rectum, and usually during the 4th decade of life, they show up. And I will tell you, they hurt. They hurt quite a bit, and they interfere with your ability to do number 2. Okay, and very much so, all right? They do bleed sometimes. Usually it's a little bit of red blood. They'll describe it as being on the paper, or they might see a little bit of blood in the stool, okay? It can result from pregnancy or, again, portal hypertension. So there's no rhyme or reason for it. These guys can actually prolapse and come outside the sphincter as well. So, and again, these are very painful, and again, remember, you're kind of closing up how much room there. Now, the good news is there is ways to treat it. Bad news is nothing that we're going to do. Internal hemorrhoids, again, they cause a straining in the closed state. And then the external ones is it's a thrombosis of the vein, and followed by lifting and straining. And usually you have to strain. It makes it worse when you're trying to have a bowel movement. Again, it rarely causes significant hemorrhage, but it kind of freaks you out when you first see it. And again, if you do break them, actually, they can have a fair amount of blood loss, especially if they're big. With that being said, again, they do make the preparation H. That's actually what it does, is it shrinks the vessel. It's an alpha agonist, so therefore it shrinks blood vessels. So the thing with preparation H is you stick it up there, you squirt it in there, and boom, have a nice day. It shrinks and it reduces the pain and swelling, and you feel better, theoretically. Okay, they can get to the point where you actually have to use steroidal materials in order to reduce the swelling. Again, we don't push the hemorrhoid back in, by the way. I don't know who came up with that lovely visual, but again, we don't stick our fingers in those orifices. Next question. All right. Rectal foreign bodies. Again, the foreign body is inserted. They do it either because they've got a psychosis or sexual gratification. Let's see here. I'm going to name some of the objects that I've had to help assist or were stuck up there. There was a 12-inch dildo that a family decided to shove up the guy's butt because he had raped a girl and he got acquitted from it. So they took him out in the forest and inserted a gigantic thing up there. They got past the sphincter, so unfortunately they had to actually go up to L&D and dilate him out. Yes, guys do go to L&D. Let's see, gerbils, other materials, Coke bottles. Yes, if you can think of it, it's probably been shoved up there. Okay. Pool cues is the other one, and it actually caused an evisceration. The guy's laying on the pool table in the prone position, and yeah, he's got half of his gut it's prolapsed rectum. Yeah, absolutely crazy and nuts when you get there. And again, you take a deep breath and you treat the patient. Again, they can also do this. You can get foreign body blockages from the swollen foreign bodies. Again, you're going to get rectal pain and pressure, and again, it's a supportive care. Most of the time, they usually call because everything is so backed up that they can't get it out. Now, irritable bowel disease, let's see here, includes abdominal pain, cramping, altered bowel habits, and usually that altered bowel habit is they start having a lot of diarrhea, okay? And from a pre-hospital setting, we treat it just like any other abdominal complaint. Now, you can actually have the bowel obstruct, they can herniate, and they can, again, and when I say by herniate is there, or they can actually loop around. And they can tie themselves up into a knot. And as they try to move and untie themselves, extremely painful, okay? I mean, extremely painful, okay? And again, usually there's all kinds of causes for the bowel obstruction. But again, they're going to have a lot of vomiting because, again, there's no place for the food to go, and it's not going to go out. Okay, you can get distension, free air in there, and they can actually strangulate the segments. And look for the scars, by the way. Crohn's disease folks are very prone to getting bowel obstructions. All right, so treatment is, again, make sure that the airway is clear. Remember, you got to be prepared for vomiting on this one. Fluid resuscitation, because remember, things are not absorbing down there. You can actually have the mesentery, which is the blood flow to the bowel area, have a problem and be narrowed or occluded. Diabetics are very known, by the way, or coronary artery disease patients, atherosclerotic disease, are known to have this, and it can kill the bowel, okay, which then leads to bowel obstructions, improper functioning, nausea, vomiting, diarrhea, okay. And again, the bowel is going to die. It's going to get gangrenous. It's going to cause infection. And by the way, that usually means that you have to cut the bowel out, get them to the hospital. This one we get called to a lot because, again, the 10 to 20% of the population actually gets appendicitis. And again, it's usually the right lower quadrant. And again, they need to do a common surgical emergency in the field and no known anatomic or physiologic function for this particular guy. It's thinks to be a leftover organ from when we were rock eaters. Okay, so again, if you're untreated, it can rupture, it can spill the contents into the cavities. And the common site of pain is the McBurney's point. So when you get that question that says McBurney's point, 1 to 2 inches above the iliac crest, that is a sign of appendicitis. Okay, so again, McBurney's point right there. Again, feel about halfway up the ridge. That's where the guy is. Okay, so if it does rupture, by the way, you're going to have a lot of fever. You're going to have a lot of irritation to the area, rebounding, guarding, and tenderness. Okay, again, supportive position. Remember that this is a true surgical emergency. It is emergency. You need to get them to the hospital and to the surgeon. Okay, choleocystitis. Big, gigantic word for gallbladder swollen. okay? Usually it's due to gallstones and cholesterol-based stones. Obese people, middle-aged women, or got more than one biological child, usually they are more prone to it. And again, antibiotic therapy, they can go in and laparoscopically take it out. They can also use the sound waves. I can tell you most of the time now they go in laparoscopically and take out the gallbladder. And that's usually because it's full of stones. And it's actually kind of easy to see once you do an ultrasound of it. Okay. And again, yes, we can live without our gallbladder. There are some minor changes to diet and things that we're going to have to do. Again, palpation may reveal a right-sided tenderness or point tenderness in the right costal margin, which again is a positive Murphy sign. Okay. Yes, they love to throw McBurney. Remember, Murphy's up top because Murphy's law is always first, and then down below is McBurney's point. Okay. And then a pre-hospital treatment is usually we get them to the hospital. Yes, it is a surgical problem that needs to be taken care of surgically. Pancreatitis. This guy usually in our chronic alcoholics are kind of prone to getting these, but there's 4 basically causes of this. And again, it's like I said, it's specifically alcoholism. And it's amazing because you'll get to that same patient who's now having abdominal pain because they had a night before they went out on a binger. Well, you know you got pancreatitis, you know that it's going to hurt. And again, the problem is if you've got sepsis or shock along with this, and again, this patient's going to appear acutely ill, okay? Again, you're going to treat this a lot like a septic patient, all right? And again, fluid resuscitation, not necessarily a bad thing. And the lesions can erode. They can actually hemorrhage into the abdominal cavity. So you might get that burning and tenderness and guarding area of those areas. Again, nausea is usually followed by uncontrolled vomiting, and then that aggravates the hemorrhage as well. Okay, so again, they're going to look sick. Monitor the ABCs, supportive care for these guys. And last but not least is your hepatitis. And again, we've got multiple strains of it, but what it does is it swells up the liver, okay? Makes the liver big, enlarged. You can actually feel it in most cases, okay? The problem is that causes liver dysfunction, liver failure, in which case they usually end up dying. And again, it's usually due to, and most of your hepatitises, by the way, are transmitted via especially hepatitis A. We had an outbreak of that a couple of years ago where, people weren't washing their hands coming out of the bathroom, and next thing you know, there's a whole bunch of hepatitis A cases. Again, chronic alcohol intake also will lead to hepatitis situations. The hepatitis A is kind of easy to spread. B is usually takes a bloodborne transmission, and as you get down the alphabet, again, it's responsible spreading through blood transfusions, and is again usually less commons are your D's, E's, G's, and H's. Okay, they've got all kinds of them now, but again, it usually causes a lot of fever, a lot of nausea, vomiting. They can be very sensitive to light. They'll have a sore throat. They can have coughing along with that. So again, the large liver is the key thing there. Secure your ABCs, and then the vaccinations are available, your Hep A, Hep V vaccinations. And guys, the Hep B, yes, it will do some very serious damage to you, okay? So if you can, and again, because you're doing clinicals, I believe all of y'all have to have the Hep A, Hep V. And Recomdavax actually does really good against both of them. So again, if you haven't been vaccinated, that's a good one to get vaccinated for. All right. So again, there's a lot of things that can cause abdominal pain. Okay. I would probably know where those little signs, Cullen's, Gray Turner's, Murphy's sign, McBurney's sign, all of those, they love to throw in on there on the freaking questions. So be aware of them and know what they are. And then that will definitely help you out in the future. All right, gang, that's it for today. And I will see you on the next one.